Okay, well, I am really pleased and thrilled to have Dr. Pamela Kunz on the Healthcare Unfiltered podcast. Dr. Kunz did visit with us on my other older podcast, Outspoken Oncology, when she just had moved from the West Coast all the way to Yale mid-pandemic. She just basically just got everything on, and so
That's right.
we wanted to bring her back a year later, or almost a year later, to talk about the science, what she's been up to at Yale, and just to catch up on academic science as well as I would say social science or policy science kind of thing. So Pam, welcome back. Very, very happy to have you. A big fan of you on social media and what you and follow your work, from afar. But just for listeners, a little bit about you, and so at least they know who they're listening to.
Thanks, Shadi. So happy to be back. So I am the director of the Center for Gastrointestinal Cancers at Yale. And in fact, I think my title has officially changed since I last met with you, because we launched our center in, I think, February or March of this year. So that was one of my tasks on arriving. So I've successfully launched it, which is exciting. So we can talk about that a little bit. And then I'm also the Vice Chief of Diversity, Equity, and Inclusion for Medical Oncology at Yale.
Okay, well, excellent. So check mark on task number one, right?
Yeah.
So tell us about that center a little bit. Like, what's the academic mission, or what you aspire this to be in the next couple of years?
Yes, absolutely. So this is actually, these centers are a Yale Cancer Center-wide initiative to launch disease centers across all of our diseases. And I think one of the unique aspects at Yale is that we have a number of community care centers across the state of Connecticut. So this is actually a system network-wide initiative for GI cancers to really bring together MedOnc, RadOnc, SurgOnc across our network, and really think about broad initiatives around research, patient care, and education. So we had all the puzzle pieces. We had a GI cancer program, but it's really thinking bigger than that and trying to look at where are patients getting care, what do we need to provide to them, kind of in the patient care realm. From a research perspective, we in our Yale network can do clinical trials at many of our locations across the network, but it's being strategic about which clinical trials, what is our catchment area, what do we need to be doing, what diseases may be more prevalent in the state of Connecticut, et cetera. And then educational initiatives, both in terms of patient care, CME activities. And so it's been really fun to think about that. So I have a leadership cabinet. I have a scientific director that's helping me, and really stakeholders that really contribute to all of these different missions for GI cancers in the leadership cabinet. And then under that umbrella, we are focusing on developing 4 disease-specific programs, hopefully more later, but we're focusing on pancreas cancer, colorectal cancer, advanced hepatobiliary, and neuroendocrine tumors.
So the how big is the network across the state of Connecticut?
So we have 15 care centers. So these are separate facilities. We have also some other hospital systems within the Yale New Haven system. 50% of patients with cancer in the state of Connecticut make it through the Yale system at some point. So we actually have broad reach through the state of Connecticut.
Right. But your idea of creating the center is you want to kind of standardize some of the, so if I was seen by you in the main campus, I get the same recommendation as if I was 50 miles away.
That's right. So I'd say from the patient care standpoint, it's the same signature of care. That's the intent throughout. So what that means is having, regular meetings to talk about that and do some standardization. So in fact, just today we had a meeting, we're talking about multidisciplinary care throughout the network and implementing that, and how do we make that work. And geographically, there's some differences in where we're all located, and we're trying to be, I think one silver lining of the pandemic has taught us that we can be creative with telehealth, creative with having Zoom meetings that bring these people together in different geographic locations. So I think we're still really at the beginning of implementing some of what we'd like to do, but I think we have great buy-in from all of our different stakeholders. And it's, I think, as you know, in an academic system, the goal also of this is to really break down some of those walls in the academic matrix, so between hospitals, School of Medicine, Cancer Center, et cetera.
But I really like what you said, because I think one of the issues is many patients are just unable to always travel and see the key experts at large academic sites. So I think bringing the expertise to them is really important. But as I was listening to you, I was wondering, do you feel that this will require having specialized oncologists in the community, or do you think general oncologists with some academic flavor to understand what's going on?
So we already have that to some degree. So our care center system has been in place now for many years, and many of our care center physicians self-identify with a specific disease center. So that may mean that they are, a general oncologist 50% of the time, but then 50% of their patients are GI cancer patients.
Right.
And so I think in some are more focused than that, and some may be a little bit less focused, but they still have a home in a disease center. And I think the goal is to provide education and some consistency. So one example of that, we started a seminar series that we meet weekly, and we have a journal club, two scientific talks per month, and a more clinically focused talk per month, and are also starting to invite some of our industry partners to have conversations around pipeline and investigator-initiated and other scientific opportunities.
I think really the culture of collaboration and between academia, community, and industry is hopefully going to really lead to improved patient access and care. And then you said there are the 4 areas are pancreas, neuroendocrine tumor,
colorectal, and advanced hepatobiliary, so metastatic HCC cholangio.
So did you choose those based on their prevalence in your community, in the state? Like, for example, I don't know, like there's no upper GI cancer or stomach cancer.
There isn't yet.
Oh, okay.
It's, I think we picked these based on local expertise at this point, and where we already have some traction. So our pancreas program has already actually been quite successful in bringing folks together, both on the basic and translational side and the clinical side. We do actually have, in the state of Connecticut, a higher incidence for pancreas cancer than the US SEER population. So we accrue well to pancreas trials. So that was a really high priority. I would say, colorectal is probably our next to really officially launch. I think, especially nationally now with the guidelines changing for colonoscopies to the age of 45, and we have a very diverse catchment area around New Haven. I think we really need to better meet the needs of our patients. And so really thinking about that colorectal, both screening, we're linked closely with our gastrointestinal colleagues and starting to develop more programming around that.
And I think last time we spoke, you said, as you move, that you're expecting to recruit a lot of faculty to fulfill these needs. So how is that going? Have you been doing okay recruiting? You can never be done with recruiting.
I've never done recruiting, but yes. So actually we have my first faculty recruit is starting in August. So her name is Dr. Laura Baum, and she is joining from Vanderbilt. She was a trainee of Dr. Kathy Engs and Jordan Berlin, who I'm sure you know. And
of course.
So we are happy. Someone, I think you might have seen this on Twitter, someone coined the term like the, onco family tree. And so Kathy and I are, sharing, she's passing the baton. And so we're really excited. Laura has an MPH and is also palliative care trained. So her area of research focus will be in health services. She has an interest also in opioid addiction and cancer patients. And I think that plus her palliative care background and expertise will just be awesome for GI.
That's great. Well, congrats. I mean, you're just doing amazing. I mean, just in less than a year, I think you moved in July last year. Was it
Yeah,
July?
yeah.
Yeah, this was I mean, tough moving in the pandemic, wasn't it?
Indeed, yeah. It's my kids finished school today, so it kind of forced me to think about like the year and what a year.
Oh,
So
that's late. They just finished?
yeah, yeah, late for us.
Oh, okay. Yeah, no, mine are they just finished middle school, so they finished a couple of weeks ago. So I think, we just finished the virtual ASCO meeting. We just had a virtual ASCO meeting. I have to admit, it's very difficult to focus with me.
I agree.
I love watching the presentations, honestly, and pausing the presentation, rewinding, looking at the slides. Don't get me wrong, but I can't. Just impossible. I don't know. So next year, I promise you, everybody's going to be in Chicago and we will meet in person. But I thought we will pick the neuroendocrine tumor area because I know how passionate you are about, and obviously you're a world-renowned authority in it. But and given that ASCO just happened, I thought it's a good opportunity. Maybe you can tell us a little bit about the neuroendocrine tumor in general. Why suddenly, like, I feel there's more interest in it. I can't say suddenly, but maybe I became more aware of it.
Mm-hmm.
And then what piqued your interest at the last ASCO meeting pertaining to neuroendocrine tumor that might be really more clinically applicable and patient relevant?
Sure. So I will say the caveat is not a big year for net research at ASCO, but I'll mention a few studies, and then maybe I'll mention also we had a really exciting National Cancer Institute clinical trial planning meeting just in March. So since I spoke to you, so I can maybe speak to that also. At ASCO, I'd say maybe I'll mention 3 studies. So
before that, what I want to make sure folks know what neuroendocrine tumor is.
Oh yeah,
because sometimes not everybody who listens. And is it I just became more aware of the neuroendocrine tumors, or is it more prevalent suddenly, or there's something over the past 5 years about neuroendocrine tumors that wasn't there 10 years ago when I don't know.
Right. No, I think all accurate. So neuroendocrine tumors, and actually we're now even really calling them neuroendocrine neoplasms because they include both the low grade, which are the WHO, World Health Organization, grade 1 and 2 neuroendocrine tumors that are more indolent, slow growing. And then they also include the high grade or grade 3 neuroendocrine carcinomas. So that distinction is important. It's sort of a nuance that like tumor versus carcinoma. Carcinoma implies that it's higher grade. And Jadi, I think you're right that we have seen an increased incidence over the last 3 decades. I think that's in large part due to improved diagnostics, incidental findings on colonoscopy, screening, lung cancer screening scans, and I think better awareness of our pathologists, both in academics and community, where we're just better at diagnosing them. I'll remind the listeners that the term carcinoid used to be used to describe these tumors and actually means cancer-like. So it was really only, in the last 15, 20 years that these were actually really recognized as cancers by the SEER registry. So some of the distant epidemiologic data is just inaccurate because these weren't even coded as cancers a while ago. So I think
there's a lot of pathology in understanding the diagnosis.
Yes, and the pathology is confusing and the nomenclature has changed a lot over the last decade. But I think the neuroendocrine neoplasm, neuroendocrine tumor is where we are. We've sort of fallen away from using the word carcinoid. And then they can originate in almost any part of the body. So the most common are in the small intestine and in the lungs, but we also see them in the pancreas, that they can originate just about anywhere. And we now really, I think, understand better that these different primary sites have different biology. They're being studied now in separate clinical trials. So our FDA approvals are different for pancreatic NET than they are for lung NET, and the trials are being designed that way.
That's really fascinating. So you could have a drug that's approved for neuroendocrine tumor pancreas, not approved for neuroendocrine tumor lung.
Yeah, so sunitinib is approved for pancreatic NET and not approved for any others.
So the site of origin matters in addition to the actual pathology. On the
That's right.
On the molecular level, are they also different, or we don't have enough data on the molecular level?
We think that they are different. I mean, I think we've seen in the last 5 years or so. So I think, to your point, the timeline is probably the last decade. We hadn't had FDA approvals for years and years until about 2011. We started having some FDA approvals. So it's been in that time frame that I think we've seen more interest and more awareness. But to your question on the molecular profiling, in general, the well-differentiated grade 1 and 2 neuroendocrine tumors are very mutationally quiet. They do not have a lot of somatic mutations. They generally have low tumor mutation burden. So on that, scale of tumor mutation burden, they're on the very low end. For pancreatic NETs, common somatic mutations are in the MEN, or multiple endocrine neoplasia pathway. So somatic, not germline, DAX and ATRX, and the mTOR pathway. And what's interesting is that I think there was a paper, I'm trying to think of when that came out, in the kind of also around 2010, that demonstrated that. But meanwhile, we already knew that mTOR pathway inhibitors like everolimus were effective in this disease. So the clinical science really was way ahead of the basic biology understanding.
Yeah, it's one of those things where you know the drug works, and then you go back and say, why is it working?
Yeah.
So before ASCO, and I know you're going to highlight three areas of interest, at least. Maybe they were not earth-shattering, but to understand why you're highlighting these three areas before ASCO, are there general themes into how we approach neuroendocrine tumors, whether they're metastatic or localized? I guess
Yeah, I think of sort of key features that help us think about how to treat these patients. And then I can also mention what is sort of the hot area that would actually lead very well into talking about the clinical trial planning meeting. Right. So, we think about the things I mentioned already. So primary site, we think about the histology. So the grade, is it localized or metastatic? Another really important factor is whether they produce hormones or not. That's called functional or non-functional. So the classic functional NET is carcinoid syndrome. So that's the secretion of serotonin. We often measure that in the urine as urine 5-HIAA. Another key feature that really just in the last few years has become important is the presence or absence of a somatostatin receptor. So this is present on the surface of probably 80 to 90% of the cells for patients with the well-differentiated or low-grade neuroendocrine tumors. We can tell this by a gallium-68 PET scan. This is it replaced the Octria scan, which was the older form of identifying, presence or absence of the somatostatin receptor. This matters because we actually now have a therapy for this called lutetium-177 dotatate. This is a beta-emitting peptide receptor radiotherapy. I'll mention, just because this is a less common disease than prostate cancer, but one of the hot trials at ASCO this year was a radioligand therapy for prostate cancer. So, this radioligands have been around for a while. Lymphoma had some, success in that many years ago, although maybe not used all that much now. But I think that the radioligand therapies for solid tumors are really taking off. So I'd say that the kind of hot space right now in neuroendocrine tumors is this radioligand therapy. It's also called PRRT, or peptide receptor radiotherapy. And the National Cancer Institute, as you know, has task forces or steering committees for diseases. So in GI, there's a GI steering committee, and then under that GI steering committee are a number of task forces for specific diseases. So I chair the Neuroendocrine Tumor Task Force. And every once in a while, we can host a clinical trial planning meeting. The last one for NETs was held back in 2009. So about a decade later, we're hosting another one.
Oh my God.
I know. So, it's funny. It was really sort of a full circle moment for me because I attended that as I think I was a senior fellow in 2009. And then I had the opportunity to lead this one. So it was really fun. And I think, that the manuscript was published from that. It really set the tone for the next decade worth of clinical trial priorities. So our task this time, the format has changed a little bit over the years, but our theme for this meeting was clinical trials in the era of PRRT for NETs. And so we had to really think about, this was incredibly practice changing. This trial that led to the approval was called NETTER-1, and it PRRT or ludotate was approved in 2018. So we've now had it available for about 3 years. So for our listeners, it is an infusional therapy. It's given once every 2 months for 4 total treatments. And this is only for patients who have somatostatin receptor avid disease after progression on octreotide or lanreotide. And what was I going to say there? I lost my train of thought. But so it's a second line treatment basically. But
Pam, a couple of questions before we go to other therapies and then the trials at ASCO or the abstracts. If you have localized disease, I could imagine if somebody has localized neuroendocrine tumor in the colon, it's probably not difficult to resect. I mean, it's always
resect, absolutely.
Right. But if you have it in the pancreas, like if you have a neuroendocrine tumor in the pancreas and you need like a Whipple and all of that, are there, like listening to you, I feel like the neuroendocrine tumors have a spectrum where some of them could be, there and they're not functional, they cause no trouble.
Right.
And some of them obviously cause trouble. Are you able today to, when you see a patient, to tell, what, yours is indolent, we can actually monitor? I did lymphoma, so there's like this indolent lymphomas where you could just watch and wait. Like, is there a watch and wait in neuroendocrine tumors?
There is a little bit. So I'll give you there are probably 2 scenarios. So for a patient with a pancreatic NET that may be less than 2 centimeters, where we have a biopsy and it's proven to be a grade 1, very slow growing. You're familiar with the term Ki-67, that proliferation rate. So if it's, like 1 or 2% of the Ki-67, we might recommend monitoring. Also for patients with metastatic disease that have very low grade, low Ki-67, we might recommend monitoring frequently and then only initiating treatment at time that there's clear progression. So there are some situations like that. I would say more so for small intestine NETs that tend to be more indolent than pancreatic NETs that tend to be a little bit more aggressive.
Got it. Okay. So, ASCO wasn't earth-shattering, but maybe there's a couple of abstracts that just caught your attention, and it doesn't sound from listening to you, management is not going to change.
No change in management. That's right. Yeah. So I had mentioned that the PRT, the 177 ludotate, got approved on the basis of the NETTER-1 clinical trial. So there was an update of overall survival on that clinical trial. So it was maybe I'll rewind a little bit, most of our neuroendocrine trials use a primary endpoint of progression-free survival. So that's different than a lot of other solid tumors. And that's, I'd say, primarily for the reason that because this is a more indolent disease, OS is a really impractical endpoint. Patients go on to get many subsequent therapies. It's too tough to use that as a primary endpoint for most NET trials. So NETTER-1 had an improvement of progression-free survival of the treatment arm compared, the control arm was octreotide. And there was a hazard ratio, I think, of, close to 0.3 or something. It was like a pretty remarkable hazard ratio. And the OS was not mature at the time of that initial report. So it is mature now, and there was not a statistically significant difference. The thought was there was about a 30 to 40% crossover rate for patients going from the control arm to getting the experimental Lutathera treatment. And so that was one explanation for that. But the difference was about a 12-month difference, 12 to 14 months. I can't remember exactly. But I think that's a clinically meaningful difference in terms of overall survival for that patient population. So there was some debate on that, like, does that matter? Do we still believe the treatment? Is it still effective? And I think it's an impactful treatment. The difference in PFS was about 2.5 years. So it's it's a meaningful treatment for these patients.
Yeah.
So that was one study.
Yeah, and it will endorse the current practice, so it wouldn't.
I think so.
Yeah.
Yeah, I think so. It won't change the current practice for sure.
No, honestly, I always say it's great that the authors and the investigators did provide longer term follow-up. I mean, there are many times where you don't see the longer term follow-up. I'm seeing more of that recently, including some of the negative, somebody might interpret this as negative. I think this means it's just the same.
Yeah, I agree.
What else?
So there was a study on Serofatinib. And so this is another tyrosine kinase inhibitor, but it also hits a target of colony stimulating factor 1R. So Serofatinib is a relatively new drug, and it's thought to have this combined angioimmune mechanism. It was studied in 2 large phase 3 clinical trials in both pancreatic NET, separate from extrapancreatic NET in China. Those reported out just prior to GI ASCO and were both positive, so showed a prolongation of progression-free survival in both of those settings. But we hadn't studied it in the US. So this study was a phase 1-2 study of Serofatinib in the US. So it basically reconfirmed the same adverse event profile and also demonstrated sort of early efficacy in a small population. But that was what the FDA required in order to submit a new drug application in the US. So that NDA is sitting with the FDA right now.
So was that a single arm phase 1-2 in patients who failed everything else?
Let's see, it had to have been at least probably 3rd line therapy.
Octreotide and sunitinib maybe.
And something, well, I don't think they could have had a prior TKI, but I would have to double check the eligibility, Chadi, but it was definitely a later line therapy. But they had to have demonstrated, some level of safety and efficacy in the US population before, but they could still take advantage of the phase 3 data that our colleagues in China produced.
Yeah, it's interesting though. It makes you wonder because Serofatinib seems to be working similar to sunitinib just in terms of mechanism of action. In the US, I believe most of you specialists in that disease use sunitinib. So will be interesting to see what that means because you would want to know if the drug works after sunitinib to be used, unless the company wants to bring it early on and compare it to sunitinib. But today, first line therapy is octreotide. Is it like it remains octreotide, right? First line.
Octreotide or lanreotide. So lanreotide is a very similar somatostatin analog. They're made by different companies. They have the exact same mechanism of action. They're administered slightly differently. So octreotide is an intramuscular injection and lanreotide is deep sub-Q. They're both given monthly for tumor control. And they're used pretty interchangeably. And I would say those are pretty standard first line for the low-grade neuroendocrine tumors. How the caveat to that is if someone, especially a pancreatic NET patient, has bulky disease and they are symptomatic from tumor bulk or high volume disease, we might consider starting cytotoxic chemotherapy with temozolomide and capecitabine.
So temozolomide and capecitabine are your go-to choice of chemotherapy. Okay, you promised us a third abstract.
Yeah, the third abstract. So the third abstract was a small phase 1 study, and I'm going to just use this as an example of how the radioligand therapy is of interest. So this is with an alpha targeting therapy. I'm having to go back to physics, Chadi, and relearn. I'm not a nuclear medicine specialist, but I'm having to learn a little bit about that. So this is with an agent called lead-212. So back to our periodic table, and it emits sort of alpha particles. And so again, very early phase 1 study, but the potential, and it's still a somatostatin receptor targeting agent. So I sort of recently did one of those GI Oncology Tumor Board Tuesdays and sort of did a tutorial on why somatostatin receptors are the perfect target. And they're not really historically thought of as a molecular target, but they really are because we now have, these radiopeptide therapies. They're increasing, and that can be alpha emitters or beta emitters. We also are starting to study antagonists to the receptor, there are drug antibody conjugates, there's some bispecific antibodies. So this is a really active area of research. So that third abstract looked at the alpha emitter.
You know, it's really interesting. You know, one of the things that you highlighted, how the radio labeled antibodies or the radio conjugates in lymphoma. I mean, goodness, I was a fellow. One of my
Me too. I was a fellow too.
I mean,
Bexar and Zevalin.
I wrote a case report one time on Zevalin causing secondary leukemia a long time ago, but they never really picked up. And I think the reason is, amongst many reasons, logistics were always difficult to figure out. Medical oncologists, nuclear physicists, radiation oncologists, who's doing what, who's administering where, and all of that stuff. As you think, I mean, I don't know, I hope you're learning from the lymphoma community so you could do it much better than we did. And I mean, is this usually discussed with you and your colleagues into when these make it, how we're going to do it?
Yeah, I mean, I have to say one of my most interesting experiences was taking ludotatate from a clinical trial setting. I was at Stanford at the time, we had it open, and then operationalizing it to standard of care. And that was actually a really great educational experience for me. It was super complicated. And it does require, I mean, really close collaboration with nuclear medicine and the radiation safety team and the nursing infusion team. And I would say now, most places are in a good rhythm of how to do this. And this is an outpatient treatment, so it does not require being in lead-lined rooms and overnight. So it's a little bit easier because it can be done in the outpatient setting.
Great. So now you're running the program. So this is your administrative hat. You're doing the research. You're taking care of patients. And how? I mean, do you see patients 2-3 times a week, or what's how?
Right now I'm seeing one day because of all these other hats that I'm wearing.
All right, excellent. And inpatient, you also have to do some inpatient work.
I do.
So when do you have time to do the other part, which you want to tell us about, the diversity, well, first of all, tell us what that means, and then when in the world do you have time for that again?
So in between times, but it really fills my bucket. So yeah, we'll talk about it. So I'm the Vice Chief of Diversity, Equity, Inclusion for Medical Oncology. And this is in the Department of Medicine. And this is a brand new initiative at Yale. And there is a DEI Vice Chief for every division in the Department of Medicine. I think we're meeting in like a week or two for our first meeting. And I think it's to really broadly bring people together. And I think our Department of Medicine chair is, been very committed to DEI. And I'm excited to be part of this. And I know I've talked with you about my sort of personal journey and interests in gender disparities that actually played a pretty prominent role at ASCO this year, equity broadly, but I think we had some great panels and conversations around gender equity in oncology at ASCO. And so I have found this to be involved and to be thinking about solutions as really empowering. And I'm excited to be part of, being part of the change.
So when that committee is formed, I presume there's a larger mission for the department, and then there's maybe a smaller mission for each division because each one may be different. What is the mission statement or the top 3 things that the whole committee is trying to accomplish? And is there a timeline? I mean, I realize progress takes time, but what are the top 3 things, if you will, that are outlined as part of the mission of this committee?
So that's a good question. I'll come back in 6 months and talk to you more about it. But I can tell you what I think are perhaps some low-hanging fruit and top priorities, just because I have started talking with people a little bit, but we haven't had our initial meeting yet. And I talk about this when I talk more broadly about DEI. I think really one of the first steps is collecting data. And I think that many of us in our own institutions, in professional societies, that's a really great place to start. And collect data on diversity metrics, collect data on sexual harassment, create a way to do that. Because I think if you don't know where you're starting, it's hard to know where you're going. And so I think would be great. I know as a personal goal of mine, I think we really would like to increase the diversity of our faculty. I think that, in recent conversations I've had, I don't know who said this, but, instead of the saying, great minds think alike, great minds actually think differently, and to really bring in people who have different opinions, different point of views is super important to, I think teams are more successful when those opinions are different.
Yeah, it's really interesting. I do believe the diversity in opinions is really critical and important. I also think that it does require people in that committee to be willing to have difficult conversations. Not all the conversations are comfortable.
I agree.
And I think sometimes what I found that people struggle with difficult conversations because you always, like, even if you want to try to have a difficult topic and you want to discuss, you have to put it on the table and just say, okay, this is not an easy topic, let's talk about, which means that there could be various views and so forth. And I think, I don't know, my observation is not all topics are discussed in easily anymore. Like there's a lot of difficulty. And have you noticed that? What are your thoughts there?
I agree. And I also agree with your point that we have to, lean into being a little uncomfortable. And I think that's okay. I think we're going to have to do that some to solve some of these really challenging issues around diversity, whether it be race, gender, because some of those are going to be really hard. And, I think I want to make a point that around the topic of intersectionality, because I think, my sort of personal experience has all been around gender disparities, but I think that other women or other faculty who may have other characteristics that may be underrepresented or marginalized, whether it be BIPOC, LGBTQ+, disabilities, et cetera, I think can have additional burdens when these different characteristics intersect. And that concept of intersectionality was actually coined by Kimberly Crenshaw, who is a law professor in New York. And I think that's just really important to think about as we're thinking about DEI efforts. And so I recognize what I bring to the table, my perspective that may not be representative of everybody else's.
I also think, one of the important, and I'm curious to hear your thoughts on this because you have had your own personal experience, which we have talked about previously, and it's been publicized in the press and so on. But one of the things is, if there are others who may challenge the opinion and say, well, my view of diversity and inclusion is different than your view. We both believe in that, but I would go around it differently. I think it's this too extreme. This is not extreme. I think we need to be, and my vision is we need to be open-minded to listen and understand so we can really do that. And I know you do, because I do know that, you listen but I don't know if everyone is able sometimes to listen to difficult contrarian opinions.
Yeah, you make a very good point. When I've talked about this concept of disparities or sexual harassment in particular, I think that it also goes back to this broader concept of creating a respectful workplace. And then that goes to your comment about we have to be respectful when we're having disagreements and come from a place of being open-minded. And I think that creating a culture of respect really matters to me, and I think is something that we all probably can do a better job of. I'd say, in all industries, but in academics in particular.
Yeah, and you represent oncology, and you said you have one person from each division. And you're meeting, so I'm really looking forward to learning more about that meeting. But in your own, obviously, you come in with some goals you would like to accomplish, and I'm pretty sure you're going to try to push for some of these goals as a member of the committee. So we're not going to spoil the surprise. We're not going to let the committee people know what you're going to tell them. But in general, a year from now, where do you like things like tangible things, right? Like where do you want in oncology, at least, things to be?
So I think we need to diversify our faculty, for sure. I think there have been a lot of publications recently on how underrepresented Black and minority physicians are. I think that's super important. I think that we, I think back to our ASCO meeting where the theme was equity for every patient. And I think that the flip side of that coin is diversity in our workforce, because I think we won't be able to provide equitable care unless our workforce is more equitable. And so I'd like to really see some progress there. One really practical tip so we had a gender disparities panel at ASCO, but it was really focused on solutions. And one of our panelists was Dr. Hannah Valentine. She is a cardiologist. She was the inaugural chief of, I think it was like workforce diversity for the National Institute of Health, a position she held for, I think, over 5 years. And she instituted a lot of really interesting changes, one of which was a concept of cohort hiring. So hiring groups of individuals together to help create a sense of community and inclusion and diversity all together, really investing in those individuals, creating mentorship plans. And that worked very successfully at the NIH. So I think that is something that many institutions are now thinking about. I would really like to bring kind of more talks around. So many institutions, Yale included, we have a grand rounds for our cancer center. I would like to bring conversations around these topics in really a more public forum. I'll give one example, because this is something I spoke about. Actually, I think it was last week. Or was it earlier this week? This week's been a blur. I was on the NCCN policy summit this week, and about how to deliver equitable care. And so I was talking some about workforce diversity, and about equitable patient care in particular. And I think we need to do a better job of taking care of our LGBTQ+ patients. And I think that there are some really sort of simple things that we can do that include more inclusive language and guidelines, and more inclusive language for the way we talk about, I'll give an example, like for breast cancer care of, if we have trans women or men with breast cancer, like we shouldn't be having everything all pink and having them wear robes with pink ribbons and saying that there's a husband support group for husbands. I think we just need to use more inclusive language. I've learned that from colleagues who've taught me that, and I'm still really learning in that space, but I think that's an opportunity. And so I want to bring conversations like that to our community.
No, these are very important conversations, and I would say it's important to bring the conversation. My ask has always been, and one of the things I always try to promote in this podcast is, I want people to disagree on opinions, because the only way to figure out how you move forward is to understand various opinions, why there are disagreements, and how can you really move forward. So I often actually bring always two people of different views, whatever, they're like, hey, let's talk about those two things, and I moderate a discussion, because I think people realize that there are always different views of certain things. Like, for example, I don't know where the pink color for breast cancer came, to be honest, but yeah, when I was a fellow, it was just all pink. So is it offensive, not offensive? I don't know, but I think talking to, like, if you are on the committee and somebody says, well, it's okay to keep it pink, and you say, no, it's not, I think having the two different views should always be welcome. I feel it's going to be the only way to move forward.
I agree.
Yeah. So, and the other thing is, do you have the, in terms of, one of the things that I really think are important is in fellowship and residency, because a lot, like when I hear you talking about the recruitment, right, you want to get more faculty in, let's say, minority population, let's say, whether African Americans or other ethnic group or races, that has to start from residency and medical school.
I agree.
Because you're not going to find the faculty unless you have the fellows. So are you working with the GME and like with medical schools, or how do you do the intersection there?
Yeah, that's a good question. I mean, we are linked with our Dean of Diversity for the School of Medicine. Dr. Darren Lattimore is excellent. And there's actually at Yale and probably in many institutions, we actually have a kind of brand new strategic plan around DEI. I would say kind of more directly, I'm involved with fellow recruitment. And we have also made a really deliberate effort at recruiting fellow candidates who are from underrepresented communities. And I think that's really exciting. So I'm a core faculty member for our fellowship. I do a lot of the interviewing, and I completely agree with you. It's, how can we attract and retain great fellows across the board, but that also helps with our diversity efforts.
Yeah, I mean, you need to get the pool of attendings, you need to get them trained. So that's an issue. And I am seeing improvement in that, actually. I mean, especially with seeing the fellowship graduation and so forth, I'm seeing that. If anybody could do it, it's you, Pam. If anybody could do it, it's you. No, it's true. I mean, I think, partly because you did have a personal experience, honestly. And I think sometimes, let's face it, I think many times, if you haven't been in the shoes of somebody, it's easy for you to criticize or say something, right? And I mean, your story has definitely been very alarming. And I think you bring the voice, I always say, like, the voice of the patient into the thing. So you bring the voice of the individual who did suffer from something like this into it. And I hope you have the resources to be able to do it, because it seems like Yale is committed to this.
They are. I mean, I have % effort towards this new activity. So I think you're absolutely right. That's really key. We can't ask people to do DEI work without compensation.
Are you seeing similar efforts across various academic sites? And then are you seeing, take away the academic sites, there are healthcare systems, right? There are community hospitals and so forth. You may not know the answer to this, but are you seeing other efforts outside of Yale, outside of academia and so on?
Yes, definitely. So I'd say, broadly across academia. And I think that not only, diversity is one piece of this, the equity and inclusion piece of that acronym are also really important. I can give a couple of examples. I'd say one area I'm also really interested in is industry relations and how industry can play a role in this as well. So I've actually am quite involved with a number of industry partners around the gender disparities piece, and have spoken, am involved with an initiative right now to look at diversity of advisory boards. And so I think that's exciting. There's more awareness around that. And then I just mentioned the NCCN. So NCCN is very powerful in terms of its kind of links with creating policy. And I think that I was on a panel with, a woman who was the head of the, sort of a Medicare payer from Tennessee, and someone who also was a leader in a patient advocacy group. And it was a really exciting meeting. I'd encourage you or the listeners to look at that. But it's, I'm personally becoming more interested in policy change, because that's also a way that we can enact some big changes.
So my last question to you, you've been very generous with your time, by the way. I'm very grateful. I know it's also late on the East Coast, but my last question, because 5 years from now, do you think you'll be doing this full time?
Oh, the DEI stuff? It's a good question. I have, what's interesting is I've joked about this with friends before. I feel like I've kind of gone through a bit of a midlife crisis where I really deeply need some social advocacy in my life. And I think some of that's from personal experiences, and some of that is through maturity and realizing what matters to me. And it's interesting the arc that I've taken, because this is now very much part of my professional persona, and I'm really proud of that. So I don't know, I'm dodging your question a little bit, but
you are, and here I
but
am. Here I am on the record. I predict that Dr. Pamela Kunz, in 5 years, she's going to be doing, I don't know where you're going to be doing it, but I think you bring a lot of passion, expertise, and again, I mean, it's as you know, again, patient care is different, but I honestly see you taking a different trajectory. Could be in policy. I don't know where, but I see
who knows?
I see you doing this full time. I would say my prediction will be 5 to 6 years.
We shall see, but it certainly is. It's incredibly motivating. I'm really happy to have part of this as kind of what I'm doing. And I think what I'm trying to ask of colleagues is that we all try to look through the lens of DEI and what we're doing.
Well said, and it's really a great end to the podcast, Pam. I'm very grateful that you're always generous. You always give me and the listeners some time of your schedule, and we're going to be calling upon it. This is going to be a yearly thing, just so you know.
Okay, that sounds
good. Be like, this is a longitudinal follow-up. This is
that's right.
Okay. Thank you so much.
Thank you, Chadi.